Welcome to Module 8 in Self-Determination in the Post-Colonial World. This is a session on public health systems and using as an example the public health system of Cuba. I'm going to deal with it in three sections. First of all, to talk about social medicine or private medicine, the polemic there. Then some broad issues about health in the world and particularly maternal mortality. And finally, about Cuban social medicine. There is a very strong international consensus on the need for good universal health outcomes, and that dates back at least to the late 70s when the World Health Organization issued its Declaration of Health for All. But the means to achieve this are hotly disputed. Much of the debate turns around the weight given to public health systems. So that's why this focus on public versus private to a large extent. And the thematic question here is, to what do strong public health systems do best? And give two detailed examples if you're to write an essay about this topic. So first of all, social or private medicine. Universal health and self-determination have a very strong link because good health is foundational for the realization of the human capabilities necessary for individual development and social participation, and of course for the development of society as a whole. But the question is, what are the means available to enhance universal good health? This goes to the root of most of the debates about health these days and the right to health. And public or private medicine is at the center of it. Well, most societies actually have some sort of hybrid, some sort of public guarantee, some sort of public system, but also varying degrees of private medicine or pay for service in many cases. So some systems emphasize private and others emphasize the public or the shared. The question is really the proportions of those two. Social structures also affect health. We're not just talking about health services. Issues such as workplace safety, family planning, healthy food, tobacco use, decent housing, other infrastructure like water and transport, those sorts of things, even public security, those things all affect health too. And in a broader concept of health or social medicine, let's say, those things are taken into account. But privatized systems change the character of the way in which health is looked at. They don't just affect the access to good health care if people can afford healthcare services. They change the character by emphasizing treatment rather than prevention and ignoring most of those broader issues I mentioned, workplace safety, family planning, and so on. The public systems, on the other hand, systematically address promotional or educational aspects of health, that is to say, educating patients and making them participants in their health, and preventive health, hygiene, education, clean water, vaccination, those sorts of things that are typically part of preventive health, which are typically taken on, the burden is taken on by public health systems, not private health services. So to repeat, there's a consensus on the right to health, but not on the means. And here are some of the provisions set out in the International Covenant on Economic, Social and Cultural Rights in 1966, and an interpretation of that by the UN in the year 2000. That is to say, the right to health includes issues such as the conditions of work, which ensure safe and healthy working conditions. They stress, for example, infant mortality, the development of the child, industrial, environmental hygiene, the control of epidemic, endemic occupation of the sicknesses, as well as assuring medical service for all. Now, in the general comment in 2000, there is an additional stress on broader social issues such as food and nutrition, housing, access to safe and potable water, sanitation, and so on, and also issues dealing with maternal mortality, protecting women from domestic violence, and consistent with the Convention on the Rights of the Child to abolish harmful traditional practices affecting the health of children. So this is where we can see that the social aspects of health have great weight, and that weight has been recognized in the international consensus, which is the International Bill of Rights. Social medicine there is looking at healthcare as a broader social phenomenon rather than just a clinical process, much less a process just of treatment of illness. In Latin America's social medicine tradition, there were significant differences with the World Health Organization's social determinants of health, which is also a broader look at health. but that was said to be influenced by European social epidemiology. Epidemiology is to do with the spread, the distribution of disease, of health problems. Both of them are wider views of public health, but Latin American social medicine stressed social transformation and emancipation from dysfunctional capitalist social structures, according to Guzman. And that is why the emphasis on education and participation of the patient was so important there. So here's a few broad themes to do with social medicine. First of all, epidemiological, which the social determinants of health model stress, that is to say, mapping and explaining the social distribution of disease or of health problems. Preventive measures, taking measures to preserve health and prevent illness, that is to say, for example, things such as hygiene and vaccination. Promotional or educational, informing patients about their health, but also encouraging them to be participants in the management of their health rather than simply passive patients. And that, of course, is what we're talking about with participatory, encouraging people to become active participants in their health. So there are some schemas that have set out these ideas. The WHO has put out a number of documents on the social determinants of health. There are a number of textbooks and readers on social medicine and a wide range of perspectives on social medicine, which people interested in this area might like to go into. But the active participation in health promotion implies the development of public health policy, the creation of favourable environments. In Latin America, for example, the former president Salvador Allende was one of the most important writers on social medicine ideas. Now, he got a lot of his ideas from German doctors, Rudolf Virchow and Max Westerhofer in the University of Chile back in the 1920s. But it was said that Allende came to know at first hand the misery, lack of housing, the lack of medical care, the lack of education of the Chilean people back in the early part of the 20th century. So the idea of social medicine was also promoted in the labour movement. Luis Emilio Recabarren, leader of the Salt Workers Union, spoke about social medicine in terms of the campaigns for the conditions of work of salt workers. Allende himself, as a senator for many years, before he even became a president, refused to de-link medical from social issues. Tuberculosis, he said, was a social issue because it improved as much by socioeconomic advance as by medical intervention. Poor housing was also linked to infectious disease, and addictions were also rooted in social misery. And in his book, Chile's Medical Social Reality, which he wrote as a young Minister of Health in the late 1930s, he spoke of wanting to reclaim the social wealth and the economic potential of the nation, to reacquire the physiological capacity of a strong people, recover its immunity against epidemics, allow a better performance in national production while also providing a better spirit to live and appreciate life. This was a very broad vision of social medicine, quite different really to the focus on provision of health services in privatised systems these days. In the early 1950s, as a senator, Allende introduced a law that created Chile's National Health Service, the first national program in the Americas that guaranteed universal access. In Cuba, the idea of social medicine was embedded in revolutionary ideals, so commitment to health became central to Cuban revolutionary social transformation and its internationalism. The Cuban Revolution promoted participation within community and popular organizations and within a firm state framework, and that participation helped drive initiatives in literacy, sport, and hygiene. The Argentine doctor Ernesto Che Guevara, who was a friend of Allende's, had also seen poverty and the stunting caused by malnutrition throughout Latin America and also in Cuba. He argued that the principle on which the fight against disease should be based is the creation of a robust body. Our task is direct all medical professionals towards the task of social medicine, not only to visit and become acquainted with the people, but to find out what diseases they have, what have been their chronic miseries for years. You can see the overlap between Che Guevara's ideas and those of Allende. And speaking of solidarity and the failures in health services for the rural poor, Che, observing the failure of the middle classes to provide health services, asked what would have happened if 200 or 300 peasants had emerged, let's say by magic, from the university halls. They would have run to help their brothers. This was back in 1960. And back in 1960, the Cuban Revolution had a great lack of doctors because many of them were middle-class people who fled the island to Miami, to the US, but where they could better pursue their private practices. So even in those circumstances, the Cuban leaders at that time were thinking about what was it about the ethos or the class background or the training, the idealism of doctors that made them unwilling to go and help provide health services to the rural poor, for example. And that's at the root of understanding Cuban medical nationalism these days, with the many thousands of doctors that go out to a wide range of countries where there is a lack of doctors. Indeed, the Cubans say globally there is a shortage of health workers. Now, on the other side of the debate here, we have something which I call big money. And the question I pose here is, can big money compensate for the lack of public institutions? Because there's a lot of literature, there are a lot of authors like Jeffrey Sachs, who used to work for the the World Bank, who say that scaling up resources, this is an OECD quote, scaling up resources and private investment, scaling up financial resources for health should be a priority. The idea there is, and it's a neoliberal idea, that it is somehow the lack of resources in health that contributes to the failures, basically. So the argument here is, and it fits in with the 21st century idea of the new version of privatization, which says public-private partnerships. And that means scaling up resources means, well, whether it's resources in the public sector or the private sector, they all contribute to make a pool of resources, and therefore the amount of resources more or less determines better outcomes. So Sachs was saying something similar in his report for the World Health Organization in 2001, where he said the level of health spending in low-income countries is insufficient to address the health challenges. Poor countries can increase their domestic resources for the health sector and use those resources more efficiently. Donor finance will be needed to close the financing gap. He's talking about international aid programs here, and that will mean approximately $27 billion per year in donor grants by the year 2007. So the idea there was that donor finance, which is often used as a type of public seed money, that is to say public money, government money, which allows the introduction of other private investment, could be for profit private investment, and that sets the conditions for the entry of private commercial capital, which used to be called structural adjustment programs. The problem is, if we look at the big spending countries, there is not a clear correlation between better health outcomes and spending. In fact, the USA, which spends far more on health than any other OECD country, yet has almost the worst health outcomes in terms of care, quality, access, healthy lives, and infant mortality. Not the worst, but one of the worst when you compare with the list, let's say in the graph at the top right there, you can see the US spends by far the most, but later on we will see that, well, in the bottom right there, US healthcare ranks the last amongst the very wealthy countries there, if we look at a range of indicators. So to sum up here, well, a provisional summing up, there are problems with the big money and the privatization or partnerships approach. First of all, public-private partnerships often lead to fragmented systems and failures in coordination and in universal access. And typically they involve targeted programs to plug the gaps, that is to say, where there are demonstrable failings in health systems. And I'll come to those later on, particularly when I talk about maternal mortality. The big money approach undermines, often duplicates the coordination in public health services. So, for example, you do have private enterprises poaching the good professionals from the public health system, which is often run down and a demoralizing place to work. There's a diversion of resources to the cities because, of course, the private health practices, the private doctors make more money in the cities than they do in rural areas. And that's pretty much a universal thing, whether it's a wealthy country or a poor country. High salaried professionals chew up a lot of the resources, and curative rather than preventive efforts are expensive. They certainly burn through money, but they don't always spare as good results as those which emphasize strong preventive measures. The emphasis on treatment is always more expensive, and that includes, of course, drug companies, but also highly paid professionals. So the key words here to identify arguments that essentially neoliberal arguments that are to do with big money, privatization, partnerships are supplementation, resource pool, public-private participation, choice of service provider. And by looking for those sorts of keywords, you can see, is the argument more a neoliberal one, or is it more about a public health approach? Looking at the other side of the ledger, public institutions can offer, of course, bureaucracy, which has its downsides, but also universal and equal access regimes. And most of the Western European health systems these days have some sort of universal and equal access regimes, and that's one of the reasons why they're typically ahead of the US system in terms of health outcomes. Public institutions can also offer well-coordinated responses to public health crises like epidemics, because inevitably things like epidemics and like disasters, public health crises are also things that require a well-coordinated response, and that doesn't happen from individual private health service providers. Preventive health system development, such as vaccine, health education, that really falls on the public sector, basically. And in most of the systems which are mixed in some form or another, the public sector has to carry most of those. And if there's a very weak public sector, they won't be dealt with very well. And that's one of the reasons why the degenerating public health system in Britain and the almost non-existent public health sector in the US handled the coronavirus 19 epidemic in 2020 very badly. So the keywords here: public systems, coordination, preventive, promotional health, they're types of signifiers that you will see attached to public health arguments there. And my rhetorical question here is about the forces which help shape health worker ideologies. For example, should we share information with the patient? That is a given, really, in public health systems. But those systems that train health workers in privatized systems really think, no, that's not really important. The patient is something who is dealt with by the professional, and all of the records can be kept in the clinic, even if it's a clinic that doesn't have much history on those patients there. So a different ethos is developed in these highly privatized systems compared to the systems with strong public institutions. Looking at health in the world, I want to introduce an idea of developmental diseases, which is about effectively preventable diseases, that is to say, relatively short-term diseases which can be overcome. And we have quite good indicators on these now, thanks to UN and WHO data collection, which gives us a lot of data across different countries which we can compare. I'm going to look at maternal mortality and infant mortality because they are quite critical indicators which change. They're quite sensitive and they change quite rapidly depending on changing circumstances. And finally, we'll come back to the issue of preventive and promotional public health. Now, developmental disease is one side of a ledger of how human beings get sick and die. Basically, chronic disease, which exists across all countries, are those longer-term illnesses like heart disease, cancers, diabetes, and so on. They, of course, have their causes. There are some ways to help try and prevent them, although there are genetic factors there. They're diagnosed typically more frequently in wealthy countries, but they occur in all countries, and they're the major cause of morbidity or illness and mortality, with more than 30 million deaths per annum. Developmental disease, on the other hand, are communicable diseases with more than 15 million deaths per annum, and maternal infant conditions, that is to say, problems around childbirth, basically, which still account for more than 3 million deaths per annum. They are overwhelmingly, all these developmental diseases are overwhelmingly factors that are affecting developing countries or poorer countries, or as the WHO says, high mortality countries these days. So there's a difference between those two. A third general factor is this global shortage of health workers, which I mentioned, plus the brain drain problem for most developing countries, which is to say, if a large number of health workers, doctors and midwives and nurses are trained, there is this steady emigration of skilled workers to the wealthier countries, because typically they will look for higher wages. Basically, migration is typically predicated on, primarily determined by, the search for better outcomes, better economic outcomes for those skilled workers, unless they're trained and supported by a public health system which provides decent salaries and decent conditions of work. But that brain drain is an important issue, which I'll come back to talking about the Cuban case. So here's developmental diseases, a chart on developmental diseases, and I've listed here the top communicable diseases: tuberculosis, HIV/AIDS, diarrhea, measles, malaria, respiratory infections, maternal mortality, perinatal mortality, child mortality, and nutritional deficiency, all of which cause many, many thousands, often millions of deaths per year. And what's in this graphic is you can see the thousands of deaths and the thousands of illnesses, but there's a column, the first column there talks about high mortality Africa to low mortality America. Essentially, it's comparing sub-Saharan African countries, the rate of these deaths between the sub-Saharan African countries and North America. And what it means is that tuberculosis occurs in this tabulation of it in 2002 from the WHO, in 2003, 167 times more frequently in high mortality Africa than in low mortality America. That HIV/AIDS deaths occurred 1,200 times more in high mortality Africa to low mortality America. So you can see that the incidence of the illness and death from these preventable diseases is far higher in these high mortality countries than in the lower mortality countries there. And so the question is why? And that's what we'll look at here. And also from that discover what are the implications for developing country health priorities? Is it to do with treatment, prevention? What about chronic diseases? So the policy implications of looking at this disparity between high mortality and low mortality countries is very important. And it's most acute, or let's say more readily addressed, by looking at these developmental diseases, communicable and maternal child conditions. The developmental disease deaths are mostly preventable. HIV/AIDS these days used to be a death sentence. Now it's a question of preventive care and highly active antiretroviral treatment. So there is treatment and there are preventive measures about HIV/AIDS. Tuberculosis is also about prevention, also by vaccination and antibiotic treatment. Measles is largely cured and controlled by vaccination. There are no big outbreaks of measles in most of the wealthy countries these days because of successful vaccination programs. Malaria is a question of preventive care and has a relatively simple drug treatment. There is no effective vaccine as yet. Diarrhea is a question, and this is something that affects mainly babies. Preventive care, it's mostly cured by oral rehydration. That is to say, most of the infant deaths are typically through children being dehydrated, and typically the greatest danger is malnourished children who are dehydrated. So rehydrating them is critically important, but nevertheless, at different times in recent history, hundreds of thousands of children have died simply from diarrhea. And in the case of maternal infant mortality, it's a question of nutrition of the mother, prenatal care, and critically, and this is central, the presence of a skilled birth assistant. I'll go into the details soon. Also, to some extent, the care after birth. So let's look in a little more detail at maternal and infant mortality. Infant mortality is defined as the death of a child following a live birth up to the age of 1 year, 12 months. And the ratios are typically deaths per 1,000 live births. So in 2013, the number of global infant deaths was 4.6 million. That's a very large number of preventable deaths. Maternal mortality is lower and has been lowered in recent years. It's defined as the death of a woman while pregnant or within 42 days of the termination of a pregnancy. And the ratio here, it has a much higher denominator, 100 per 100,000 pregnancies. So globally in 2008, the number of maternal deaths were calculated at 361,000. And by 2017, the number was down to 295,000. So there has been significant progress in reducing global maternal deaths, but that is still almost 300,000 preventable deaths of mothers in childbirth. So this is why it's a huge health issue still today. There's a dreadful name called a natural rate of maternal mortality. That is to say, if mothers had no assistance at all, no skilled assistant at birth at all, they would typically die at about 1,500 per 100,000 pregnancies. That is to say, 1.5% of the time mothers would die in childbirth. But because in low mortality countries there is a fair degree and usually systems of assistance to mothers, that figure is much lower. So in maternal deaths, for example, and the graphic here is a little bit crooked, but in the OECD countries, it's typically between 4 to 60 deaths per 100,000 pregnancies. So there's a big variation there, but it's come down a lot from 1,500. In the developing countries, it ranges between 30 to 2,000. That is to say, in some developing countries like Sierra Leone and Afghanistan in recent times, it was almost the so-called natural rate. That is to say, most mothers were not getting any skilled assistance. And I'll show you in a moment what sort of help these skilled assistants can give. Skilled assistant being a doctor or a midwife, typically. In infant deaths, similarly, per 1,000 live births in the OECD countries, the rate these days is somewhere between 2 to 30 babies dying per 1,000 live births. In the developing countries, between 5 to 165. So you can see that there's a fair overlap. That is to say, some developing countries have a better rate than some of the OECD countries, which tells us that it's not simply about wealthy and poor countries. There are something about the systems in the poorer countries or developing countries that gives them some better outcomes. And back in 2013, the worst maternal mortality rate in the world was one of the poorest African countries, Sierra Leone, with 1,100. This is maternal mortality deaths per 100,000 pregnancies. The Sustainable Development Goals, which were announced in the year 2015 under Goal 3.1, was by 2030 to reduce global maternal mortality to less than 70 per 100,000. So there is a benchmark there set up, and countries report to the UN on these sorts of things. It's a useful exercise to measure themselves against their own performance, not necessarily as a competition with other countries, but it is useful also for those of us as researchers to see what sort of longitudinal progress or progress over time there has been in addressing these highly sensitive health indicators. But the WHO said a few years ago that more than half the under 5 child deaths were due to diseases that are preventable and treatable through simple, affordable interventions. So strengthening health systems to provide such interventions to all children will save many young lives. So here is a breakdown a few years ago, but the general pattern is somewhat the same, of why women die in childbirth, in percentage-wise, on the basis of 361,000 deaths in 2008. More than a third of them were from bleeding. Now, skilled birth assistance can prevent that hemorrhage. Sepsis or infection, 10%. Eclampsia or seizures, 10%. Obstruction, 6%, where the baby's misaligned. Many of these things can be prevented by the skilled birth assistant. Unsafe abortion, particularly in those countries where abortion has been criminalized and driven underground and carried out in unsafe conditions due to unwanted pregnancies. A large number of women, 50,000 back in 2008, dying from unsafe abortions. That typically doesn't happen if the termination is done in a hospital, and 25% for other. So all that goes to show is that most of these, the bleeding, the infection, the seizures, the obstruction, the unsafe abortions, all of those things can be prevented if there is a safe environment with a skilled birth assistant there. Now, another factor here is that, and here I'm referring to the Millennium Development Goals and the Sustainable Development Goals here, where there is some data on how and to what extent the improvements have been made. But again, we see the tardy effect of the US with a very high level of health spending, but the United States was said to be amongst just 8 countries that experienced an increase in maternal death rates since 2003, joining countries which include Afghanistan and El Salvador. That's from a Lancet study in 2014. Why was there such a poor performance in the US when everywhere else these figures have been coming down? Well, a very highly privatized healthcare system, exclusion of people from that system, and poor coordination, even though there are some publicly subsidized programs in the US. If we look at the position over history, how maternal mortality progress or progress in reducing maternal mortality had happened in many Western countries, it's instructive, particularly for developing countries these days. This very long history, back to 1900, where we can see the reduction in Sweden, in England, and in the US is very interesting. At the beginning of the 20th century, you can see the figure of 230. These are all figures that look very bad these days in low mortality countries, but Sweden was ahead back in more than a century ago, not because it was a wealthy country, but because it had a very strong rural network of midwives who were assisting with births. That wasn't happening in the US, where in the early 20th century, there was a very privatized system and people without money simply couldn't give birth in a hospital, for example. Now you'll see that these figures decreased through to 1950 in the first half of the 20th century. And in the US, there was a big fall between 1935 and 1950. That should tell us that something was happening in the US between 1935 and 1950. They're the current figures there, or figures up to 2005, the OECD range, which is much lower these days, the developing country range, and the natural rate. So what were the reasons for Sweden's early success and for the slower progress in the US? So I mentioned Sweden had this wide network of midwives by 1900, which was providing a skilled birth assistant to most mothers who were giving birth. And the US had a privatized system focused on hospitals, and only because of an emergency maternity care program which was introduced during World War II, which meant that poor families, poor mothers got access to hospital care, to a doctor's care or a skilled assistant's care in childbirth, did that figure come down substantially in the 1940s, basically. So all that goes to emphasize that the primary means of preventing maternal mortality is recognized these days. And there's a reference to the article there that I've been quoting to Bruyere and Van Lerberg in 2001. The presence of a skilled assistant to stop bleeding, prevent shock, infection, or obstruction. They've been the keys. Do women get access to that sort of skilled assistant in their countries? That's critical. So, except for, here's a reflection on health aid or bilateral aid between countries. This doesn't really solve the problem. Except for large-scale health training, health aid has been shown not to help very much. There were some large systematic studies done, commissioned by the IMF, showing that bilateral aid did not reduce infant mortality. And a second study suggested that doubling health aid was associated with a very small reduction, a 2% reduction in infant mortality. This was a study that was looking at over 100 countries and comparing the impact of bilateral aid on the improvement in infant mortality, the most sensitive of all of those sorts of indicators. So the suggestion there is that capacity building is very important. Health workers or human capital are needed, and the development of public health systems is very important. And more important than simply looking at the question of increasing a pool of resources. So I'm going to show a little video here about midwife training in Afghanistan, and this comes from one of the NGOs, but it shows you the area of the most successful sort of intervention in terms of health aid. It doesn't really reflect on health aid generally.
اسم ما بهار است، 25 ساله. ما در ولسوالی هم جوار ما در کلدار چون رفت آمد در اوجه داریم. خانم بود آمده تا کلینیک قابلم نبود، به سر خونریزی بعد از ولادت از بین رفت. از این خاطر یکی از دلایل بسیار عمده که من میخواستم قابلش هم می بود. اونها شاید فکر میکنن که مشکل بر ما که چون از خانه دور میرن مشکل برشان پیدا شود، ولی که من هیچ مشکل ندیدم و این شاید بعد از اینکه من رفتم کار کنم یک چیزا بر خانم شاید بگویم که هیچ گپ نیست. اما مهارت که ما مثلا در اسکلاب یاد گرفتیم، اما چیزا ما باید در ساحه عملی سر مریض برای شفاخانه کلینیکا کار میکنیم. مردم افغانستان عموما زنها به قابل‌ها زیاد نیاز هم دارن. ولسوالی دور بسیار مرگ میر زیادتر هستن نسبت به اینجا. انشالله که اگر صنفی مفارغ شد و دیگه که قابلی که تازه از دیگه دفتر مفارغ شد برن، انشالله که فکر میکنیم این مشکلات هم تا که چی که تا 100% مرفوع شد. ما 29 ولادت دادیم. بسیار یک چیز حیرت انگیز و بسیار تعجب آور است، چون قدرت خداوند آدم ببینه هیچ قابل چیز نیست.
Now, midwife training in large numbers could make a significant difference if it were really in large numbers. But we also have to look at the question of systems, health systems. And here's an example from Mongolia in the 90s, which was a socialist country which dismantled a lot of its socialist infrastructure, in particular rural health services, and this had a huge impact on maternal mortality. If you look at the graph here, which actually begins in the early 90s, but there is a period where the maternal mortality rose substantially in the 90s and then began to fall again in the late 90s as the system adjusted to that problem. It only came back to the 1990 level in about 2006. So what happened here? In this article by Janis and Chulindorj in 2004, talking about free markets and dead mothers, they're attributing the failure in rural health services to get to rural mothers and provide services to rural mothers as they had because of that dismantling of rural health services and the flood of professionals back to the cities, where, of course, private practice raises more money in the cities, basically. So maternal mortality rose from 119 in 1990 to 240 in 1994, very rapidly. You see, just a few years, a doubling of the maternal mortality rate. Then it declined to 175 in 1999, and then came down further in the 21st century. But you might imagine that the maternal mortality rate was brought down by essentially plugging the gaps in the system there. You remember the US experience where the significant reductions were only made in maternal mortality to get from, what was it, 600 in the 30s to 100 in 1950, and that was by a special program which allowed women without health insurance, as is normally required in the US system, to get access to skilled treatment. So the Mongolian system must have been plugging the gaps there to some extent to improve that catastrophic failure in the early 90s. If we look at a systematic picture of the OECD countries, that is to say, in this case, those that have over 80% of their health system public, countries like the Scandinavian countries, for example, and those that have more than 40% of their system private, Greece, Korea, South Korea, Mexico, Switzerland, Turkey, the USA, we can see that both groups have had a reduction in infant mortality rates over a period of time. From, you see the OECD average at the top there, from 26 in 1970, steadily down to 6.5 in the year 2000. But if we look at the high public expenditure countries, they were significantly better than the OECD average to begin with, and they remain significantly better than the OECD average. Similarly, the high private insurance countries were significantly worse than the OECD average. In 1970, 55 instead compared to 26. In the year 2000, 14.5 compared to 6.5. So in other words, they were worse than the average and remained worse, those with highly privatized systems. So notice, by the way, also the way in which that little survey was set up. They're picking the half a dozen who had more than 80% of their public health system and those that had more than 40% of a private health system, given that all of them are hybrids of some form here. Finally, on maternal mortality, let's look at mothers' education. We know that there's a strong relationship between the education of girls and women, with a range of social benefits, including women's health, not least women's health, also babies' health there. So in this particular report in the UN Millennium Development Goals report of 2011, it was shown that children of poorly educated mothers die at much higher rates. And what is that? Because mothers with less education have less understanding about the treatment of their children, hygiene, a range of things, the types of things that are needed to help look after their children. So a mother's education is also a very powerful determinant of child survival. Let's move on to Cuban social medicine and Cuban public health and Cuban medical internationalism. Now, Cuba has some of the best health outcomes in the developing world, certainly in infant maternal mortality, in HIV/AIDS levels, in control of tuberculosis and malaria. Yet it is a countermodel to economic liberalism. It is a public system, overwhelmingly public, guaranteed free health services. And there's been a range of different debates, propaganda debates over the years about this. And of course, the US campaigns against Cuba, the US economic blockade against Cuba, involves a plan to privatize that very system that Cuba has in place. More recently, we've seen these Cuban missions, often called the Henry Reeves Brigades, after an internationalist from England in the 19th century who fought in the Cuban Revolutionary Wars. Those brigades have gone to other countries to help fighting the coronavirus, COVID-19, in a wide range of countries. 40 countries across 5 continents have received Cuban medics during the pandemic, as the island nation has once more punched far above its weight in medical diplomacy, was reported in Reuters in September last year. So social medicine in Cuba, I mentioned some of the roots of that before. The medical internationalism grew as an extension of revolutionary socialism and its social medicine, and health in revolutionary Cuba went through several phases. First of all, the creation of an integrated national health system through the 60s. And remember, this was after the country had experienced a large emigration of doctors. A lot of the middle classes left the country with the revolution, and that group of trained professionals had to be built back up. In the early days, there were a number of other Latin Americans that went to the country to help, and then the Cuban system itself began training large numbers of health workers and making it a requirement that all of the new health workers were salaried public professionals. Those who were private doctors before the revolution stayed on and kept their private practices going until they'd finished their careers. But all of the new doctors in Cuba from the 60s onwards until today really are salaried public health professionals. Now, then there was consolidation of this single public system in the 70s, and then in the 80s, the introduction of higher medical technology, research and services, including the development of a large-scale biomedicine industry there. Cuba sent doctors to Chile after a huge earthquake in 1960, despite a lack of doctors in Cuba at that time, and the first medical mission was sent to Algeria, which was just gaining its independence in the early 60s there, when Jose Ramon Machado Ventura led a group of 50 doctors and health professionals to that newly independent country. The Algerian program was the first of a large number of health aid missions, largely in Latin America and Africa, some other countries, but mainly in those 2 continents, to assist capacity building in newly independent countries. And from 1999 onwards, Fidel Castro inaugurated a Latin American School of Medicine, which was effectively a big network of colleges, not just one college. There is one in Havana called ELAM, the Latin American School of Medicine, but it involves a range of different colleges throughout the country to train many thousands of Cuban doctors, but also Latin American and African students, and some from other parts of the world, such as parts of Asia. The Cuban health system, as an overview, is 95% public expenditure system. It has guaranteed universal access and free care. It has the highest density of health professionals in the world, about 6 doctors per 1,000 population. And this is allowing for the fact that there are many thousands who are overseas in missions at different times. Medical training is free for Cubans and promoted. For foreigners these days, they've introduced fees, which are lower than most Western fees, but not so long ago that was free, but they've introduced fees for foreigner training, depending on the capacity of the country and the individuals to pay. It's a very highly coordinated system, which makes a point to say that intersectoral coordination, that is to say between health programs and education, public safety, transport, there's a connection between those within the Cuban system and coordinated by the state. It's part of a free-for-life education system. It has these huge foreign aid health missions and this large biotech medicines industry. Some of the medicines are quite unique. Some of them are generic and some of them are unique. For example, there is a unique Cuban meningitis pneumonia vaccine, which currently costs about $5 a dose. And the Cubans said a few years ago they hope to reduce that to $1 or $1.50 dose. In other words, they are focused on public health and accessibility and not on maximizing profits. The Cuban achievements were ignored by the World Bank, which of course is based in Washington and very strongly influenced by the US government. And so being a countermodel in terms of economic development, the US officials had tried to ignore the successes of the Cuban system until 2003, 2004, when Cuban infant mortality fell below that of the USA. And it was a time when the US infant mortality went up a little bit and the Cuban rate went down a little bit. So in response to questions, the World Bank was forced to address Cuba's success. And it did in this way in its 2004 report in an article called Spotlight on Costa Rica and Cuba, by making a comparison with another country which was not a socialist country, but trying to make the point that really it wasn't about being a Cuba-like country that led to good health outcomes. They said in that report, and here are quotes from it, that the sustained focus of the political leadership on health for more than 40 years, universal and equitable healthcare was important, concentrated on healthcare to rural areas, with the public sector as the sole provider of health services, polyclinics, which are institutions in between the local doctor and the hospitals, that is to say, small regional clinics with a range of diagnostic facilities that do most of the tests and diagnostics, so 80% of the tests that are required, mass immunizations, monitoring of health outcomes, community health programs, and highly motivated staff. So they acknowledged, honestly, some of the bases for the Cuban system. They pointed out that Cuba spends a lot of its GDP on health, although not as much as the US. But they asked rhetorically, can an approach that relies on a publicly paid doctor for every 150 families, a very high density of doctors, be sustained during economic hardship? And it's certainly the case that Cuba's been through several periods of economic hardship, not least due to the US economic blockade. Well, they pointed to Costa Rica as a type of countermodel, saying here is Costa Rica, which has similar good outcomes. And it wasn't a socialist country, so you don't have to be a socialist country to have good outcomes. And if you have a look at the table here, Cuba and Costa Rica, you can see what's behind their reasoning there, that the life expectancy in Costa Rica and Cuba is similar. The infant mortality rate and maternal mortality are similar, infant mortality a bit lower in Cuba, and at that time lower than the USA. The fertility rate is, that is to say, the number of babies women are having, which is linked to educational levels and which also has an impact on socioeconomic status, is both relatively low, 1.5 and 1.8. It indicates a well-educated population of girls and women. The mean years of schooling were both relatively high for a developing country, but higher in Cuba. The under 5 mortality rate was better in Cuba. HIV prevalence low in both countries. Adult literacy relatively high, but much higher in Cuba. Now, the GDP per capita at that time, until the UNDP revised GDP measures, was significantly lower in Cuba than in Costa Rica. And as an aside here, I asked rhetorically, the UNDP listed Cuba's GDP at $6,000 in 2012, but the following year revised it up to almost $20,000. And I asked rhetorically, why might such a large adjustment have been made? And the answer really is that when we are making these sorts of comparisons across country, typically GDP measures ignore the fact that there are free services in certain countries. And so if you are comparing a country where people pay a lot for their health services or their education services, then GDP means less. So they've imputed a value to those free services in Cuba, and that's how they raised very substantially in the year 2013 the calculation of Cuba's GDP per capita. So the World Bank's argument about health in Costa Rica was that since 1960, and I've capitalized some of their phrases here to show you the emphasis they're making, progress in Costa Rica, they mean in health, has been rapid but not too difficult to explain. Costa Rica's real income per capita increased by 25% in the 60s. By the same rate, coincidentally, they mean not coincidentally, that infant mortality declined. Income growth of 40% by 1980, along with the universalization of healthcare, saw a further decrease of 60% in infant mortality. Now, there's two things there. Income growth, which is their argument about GDP, the importance of GDP, but they've dropped in universalization of healthcare. And finally, after recessions in the 1980s, growth, they mean economic growth, has resumed, and progress on health status continues. They say one way to attain good health from initially low income is surely to stop having a low income. So you can see the stress in the World Bank's document there is, and this is what a key financial agency emphasizes, and notice what it sidelines, income growth, economic growth, stop having a low income. They are the constant emphases of the World Bank approach. What they briefly mentioned but didn't explain by talking about the universalization of healthcare was that in the 60s and early 70s, Costa Rica transformed its semi-private health insurance system into a contributory public body with universal coverage. The Caja Costarricense de Seguro Social, the Costa Rican Social Security Fund, is a central public institution which underwrites healthcare and pensions for all citizens, whether they're in employment or not. The irony of that is that with the so-called free trade agreements, the Central American ones that were lined up by the US, that Costa Rican Social Security Fund could be in line for privatization. But the fact that Costa Rica is one of the only countries in Latin America who had universal coverage and effectively universal health guarantees has a lot to do with the better outcomes that Costa Rica has there. So back to Cuba's medical internationalism, and there's a couple of good books here, one of them by Kirk and Erisman. John Kirk has written a couple of books on this. Cuban doctors have provided overseas support since the early 60s, as I mentioned, and the current tens of thousands of Cuban medical personnel abroad surpass those of the combined G8 countries, all of those rich countries. For every Cuban doctor deployed, there's usually an offer of 2 or 3 medical scholarships, and that means that locally trained students then substitute the visiting Cuban doctors and avoid the dependency on foreign doctors in the country. The Cuban doctors are trained as salaried public health professionals rather than private businesses, and they focus on rural and marginalized populations. They're also trained in large numbers, so they collaborate in maintaining that public service ethos and minimize the brain drain through emigration. What that means is that if you are trained as a salaried health professional, but you go into a system which is dominated by private practice, it's very difficult to maintain your particular project there. But if, as in the case of East Timor, which I mentioned some weeks ago, you go in several hundreds with a mission to improve the health system for your people and to change the ethos of the health system for your people, you have a lot of moral support there. If you are a US student trained with a public service ethos in Cuba and you go back into the US system, which is dominated by private doctors, then you have to fit in a different way. It's a different situation. In any case, the foreign students trained by the Cubans have to readapt as they see fit back in their own systems. But one advantage the Cuban doctors have in sending doctors to other countries is because the wages in Cuba are very low, but the social benefits are quite high. Cuban doctors abroad who are effectively seconded from their normal job at home don't contribute to inflationary economies. Whether the Cubans pay their salaries, as in the case of very poor countries, or whether, as in the case of host countries which have significant income or gain some significant income and are paid at local rates. So, for example, the Cuban doctors, when they began to be paid by the East Timorese government after some years, were paid at a local rate of $600 a month, which is much higher than a Cuban wage, but much lower than a Western wage. So they don't contribute to inflationary economies in other countries. These days, because the financing has changed and there is more concern about covering the costs of those missions, the key word is that there is a compensation provision in those agreements, the bilateral agreements the Cuban government has with other governments, or the co-financing agreements, basically. It depends on the capacity of the recipient country. There are still free Cuban missions paid by the Cuban government to countries. In other cases, the doctors are paid at the local rate. In other cases, there are more commercial arrangements with wealthier countries, like Venezuela, Brazil, Qatar, and some others, where they are paid their salaries by the local governments, but also there is some compensation to the Cuban health system for providing that mission. So it varies quite substantially these days how the finance occurs. What's very important, and the Cubans stress quite a lot, is the ethos and the values of the training. The idea here is not that they are training socialist doctors, but they are training humanist doctors. And Fidel Castro stressed this in the late 90s. He said, we're not going to teach political material, but rather complete dedication to the most noble and human of tasks, to save lives and preserve health, which is an ethos which is or should be behind the ethos of most medical professionals. In that way, Cuba is looking to minimize the conflict with a variety of countries with students under training, because, of course, there are many different types of socioeconomic systems there. Nevertheless, there's often ambivalence about accepting Cuban aid, both because of professional jealousies locally. Private doctors typically don't like their position being undermined by an influx of public sector doctors. But also in some countries, there's a fear of jeopardizing relationships with the USA. So we've seen this in a number of Latin American countries in particular. The main resistance to Cuban missions and Cuban training programs comes from local health workers who fear an undermining of their position. And there's been obvious examples of this in, say, in Bolivia, in Venezuela, in East Timor, in Papua New Guinea, for example. But those South-South programs do show a way into the radically new relations that Hickling-Hudson spoke of, necessary to the decolonization process of building independent capacity and quality in education and other fields, because public institutions and public services in developing countries are typically much weaker than in the wealthier countries. And it's not possible to develop those public institutions, public services, with the sorts of privatization programs that have become popular in Western countries in recent decades. The analysts differ over what Cuba's motives are. Its program is seen as an assertion of soft power by some, or creating symbolic capital which can be drawn on for material or political benefit. Others have suggested it's more deep-rooted and complex, a humanitarian project which might have some diplomatic, trade, or political benefits, but is not formulated simply to that end. And that's what Kirk and Erisman say. Fidel Castro said the secret of the approach was the fact that human capital was far more important than financial capital. And he stressed the point the Cubans make in terms of education, that human capital is not just about technical skills or technical knowledge. It's about values, it's about conscience, ethics, solidarity, true humane feelings, spirit of sacrifice, heroism, and the ability to make a little go a long way. And the Cubans are experts in making a little go a long way because they are not oil rich and they've depended on their human capital investing in their people for a very long time. The former WHO director, Dr. Margaret Chan, said that Cuba's medical colleges were, quote, a commitment and a contribution to a better training of the health professionals that the world needs today. Cuban training and the brain drain. I've mentioned before that there is this global shortage of health workers. The Cubans have spoken about it quite a lot, particularly in rural areas. Virtually all countries, including most wealthy countries, have a shortage of doctors and health professionals in rural areas. And they recognize that brain drain as a serious problem affecting developing countries. The Cuban doctors themselves emigrate, typically to wealthy countries at about 2% per annum. But in most developing countries, that figure's much higher. It's been 20% up to 60% at times. Effectively, countries have lost most of their locally trained doctors because they're demoralized about the prospects for their career in their own country, and they know that they can get greater compensation for their skills in a wealthy country. In the Pacific, there are almost as many Fijian-born doctors in Australia and New Zealand as in Fiji. And whereas Australia and New Zealand also have more nurses and midwives from other Pacific islands than those working in the island states themselves. In the Solomon Islands, until the Cubans took in 90 students and trained them all as doctors, doctor training was only equaling the rate of doctor emigration. That is to say, the few scholarships that typically came from Australia and New Zealand for the Solomon Islands would train some doctors, but then about the same number would leave each year to go and work in Australia and New Zealand or perhaps some other countries. Let's have a look at a small video from the Cuban doctors in the Pacific and their approach to health and social medicine.
He's the thing I have noticed when he comes in the morning, he makes sure that he sees the patient first before the rounds begin. He's really concerned with the patients. He makes sure everything is done well, the treatments are given, every orders are done before the doctors come for the round. So he's very good.
En Vanuatu, la parte por acá médica cubana que estamos acá es una misión pequeña, inicialmente conformada por 5 médicos, un especialista de medicina interna, un especialista en pediatría, 2 médicos generales y una licenciada en citohistopatología. Acá el objetivo realmente de la misión cubana acá en Vanuatu es apoyar el sistema de salud público de este país. Tiene un sistema de cooperación con los estudiantes que estamos formando de Vanuatu, formando en Cuba. En estos momentos tenemos 27 estudiantes de acá en Cuba. Sería bastante bueno cuando estos estudiantes se gradúen.
Que me dieron tus ojos, Virgen guadalupana, la tarde en que te vi, golondrina sin nido, era yo en el camino cuando te conocí.
It's really very difficult to understand the Cuban social medicine without understanding the values that underlie it. Let's look now to Cuba's handling of the COVID-19 pandemic, particularly in 2020. Now, Cuba's superior outcomes within Cuba after 14 or 15 months of the pandemic can be seen in the table below. Low absolute deaths and a low death rate per infection. If we look at its neighbours, some of its island neighbours, Jamaica, its large neighbours, Mexico and the US, we can see much lower levels of death and infections, and also a much lower level of deaths per infections. I've left Haiti out of this comparison because the test rates in Haiti were very, very low, only 5,000 per million, whether the test rates in Cuba, Jamaica, Mexico and US were all relatively high, although much higher in the US and Cuba. So the reasons for Cuba's better outcomes have been, one, strong epidemiological vigilance and a rapid mobilization of quarantine controls. Now, a number of countries did that, a number of countries didn't. The US and the UK, for example, moved very slowly. They took 2 months to put in place quarantine controls. In Cuba, there's also universal free treatment free of drug company dictates. So there's greater freedom in terms of how they use and to some extent the experimentation with new diseases of the types of medications that they use. And on top of that, there have been these brigades, internationalist brigades called Henry Reeves brigades in at least 33 countries to help those other countries with the pandemic. Once again, based on a principle of compensation, that is to say, depending on the capacity of the country to pay, they will host the visiting doctors and given their lack of capacity to deal with the strains that the pandemic in certain areas have placed on health services. So in the map on the bottom left there, you can see the medical brigades that have assisted with COVID-19 in other countries, and they've mainly been in the Caribbean, in Latin America, in Africa, but also some in Europe and the Middle East. Now, as regards vaccine sovereignty, Cuba uses some other drugs from other countries, but it tries to develop its own essential drugs for essential purposes. And so by March 2021, in the world, there were 23 candidate vaccines in phase 3 trials, actually more than 300 candidate vaccines, but only in those final phase 3 trials, 23, and 2 of those 23 were Cuban, and they were the only Latin American candidates in that group. So Cuba's medical technology is quite advanced too, and there's an article, a couple of articles there on Cuba's response to the pandemic of 2020, 2021. Looking more broadly, there is a new focus in developing countries on health because the countries, the BRICS countries, which a group which has shifted a little bit particularly with changes in government in Brazil in recent years, but nevertheless, it is a group of large countries, developing countries, which have the majority of world poverty, more than 50% of world poverty, and so they've had to take much more seriously policies which are going to affect their own people compared to the aid programs, say, of the Western countries, which often have programs which are different to the programs at home. Typically, they promote a lot of privatization in developing countries and have some substantial social institutions and social structures in their own countries there. So the principles of the BRICS process, and there's been a number of summits, and these ones were announced some years ago at the 5th BRICS Summit in terms of health, that they are talking about now committing to universal health coverage, which doesn't exist in the US, and both major parties have forsworn it basically, committing to building public systems, committing to building cooperation, international cooperation in health, and committing to low-cost medicines and vaccines. And so as a result of that trend, we can now talk about a range of health systems. I've given a spectrum of really 5 different groups here. At one end, those that may be wealthy but highly privatized and with weak public systems like the US, where you have very profitable health industries forcing their way and maintaining their position there, preventing the US Congress from introducing universal coverage, or what they call the public option there, or socialist medicine, which they're horrified by. Keeping the user pays principle in force to the point where people with some very common chronic illnesses like diabetes are paying hundreds of dollars per month just for their life-saving drugs like insulin, for example. At the other end, you've got very strong public systems, not many of them, like Cuba, for example, which I've just discussed. In the middle, you have, for example, those in Western Europe and Australia, Canada, with universal health guarantees, but a largely privatized profession. So a hybrid system which has universal coverage, access to care, but also public subsidies to the private industry and a fairly commodified service delivery system. You've got weak developing systems, which is most developing countries where there is a minimal city-based public sector, some basic hospitals, but a proliferation of private clinic networks, and then supplemented so-called by an NGO aid sector, for example. Then you have some countries which have substantial public sector growth, those that are going through significant political changes like Venezuela, Bolivia, Timor-Leste, which I spoke of a few weeks ago, which have a commitment to a rising public sector, and there's some clashes with the competition in the private sector. So that's a categorization, I suppose, of 5 different types of health systems emerging in current circumstances. In summary, in health systems, we have a significant clash between public and private ethos. Not that systems are either totally public or public-private, they're typically hybrids, but it's a clash not only which has impacts in terms of access to health services, but in the nature of health care. To what extent education, participation, prevention are stressed by those public systems. And those that have highly privatised systems play down participation, education, and prevention. Almost all countries are improving in their maternal and child mortality, but those with very well-organised public institutions, well-trained health workers in terms of childbirth skilled assistance, and universal access regimes have the superior outcomes. I demonstrated that by looking at the OECD countries. There's a big debate over the means of achieving agreed common goals over the right to health, but the privatised version of things talks about constantly scaling up resources, public-private partnerships, versus the emphasis which has now fallen into the BRICS system of building public health systems and the benefit of well-coordinated public health systems. Aid programs in health, unfortunately, add little, as 2 IMF studies have shown, unless they involve substantial human capacity building, like the large-scale Cuban training programs, which in some countries, like Timor-Leste, has really transformed the health system. The Cuban system itself is a 95% public system with a commitment to prevention and health education, and that contrasts quite strongly with the Western treatment-focused service industry, which pays less attention to epidemiology, although the WHO stresses this social determinants of health, and even less attention to the idea of participatory patient engagement in the health system. The new priorities in developing countries, however, are attempting to restore a focus on public systems, to prevention and to affordable medicines. There's a great deal of public pressure behind this. So, as usual, for some further reading, here are a few texts. The Idea of Medicine and Public Health at the End of Empire by Howard Waitskin, who writes quite powerfully on social medicine. One of the books by John Kirk, he's written several on Cuban medical internationalism. There are several volumes on social medicine, a range of different perspectives on social medicine. This one I've mentioned by Gail Henderson, the Social Medicine Reader. And finally, the Medic Review, which is a magazine and a website that's entirely set up to US collaboration with Cuba, and that interests a lot of public health professionals in the US and in many other Western countries.